Hello, everyone. I'm Brandon Hocker with the Open Minds Market Intelligence team, and I would like to welcome all of you to today's Circle Elite Executive Roundtable, Healthy Beginnings at Home, Social Determinants of Health for Women and Infants, the Caresource case study. Today's session features Kyle Lowe, State Housing Strategy Lead, Indiana Caresource. Kyle Lowe has held several roles within the Life Sciences Department at Caresource since joining in 2017. In his current role, he collaborates with developers and CDFIs to invest in the creation and maintenance of affordable housing in the state of Indiana. In addition, he designs, implements, and optimizes housing and health interventions for Caresource members. Mr. Lowe holds a BA in Spanish Literature from Indiana University and an MS in Health Leadership from Western Governors University. Moderating today's roundtable will be Kim Bond. Kim Bond brings over 30 years of experience providing behavioral health treatments in the public and community settings for the Open Minds team. She currently serves as the Executive Vice President of Payer Provider Markets. In this role, Ms. Bond provides executive oversight and leadership to all provider and payer client engagements for Open Minds. Prior to joining Open Minds, Ms. Bond served concurrently as a program coordinator and clinical manager of adult services and a program coordinator and clinical manager of recovery services for Ozark Guidance Center. Prior to joining the Ozark Guidance Center, Ms. Bond served as the Executive Vice President of Centerpoint Inc., a large substance abuse provider agency in California. Previously, Ms. Bond served as the President and CEO of Mental Health Systems Inc. Ms. Bond was very instrumental in growing the agency from $12 million in annual revenue to over $100 million and became one of the largest providers of behavioral health services in California. Ms. Bond received her bachelor's degree in psychology with honors and her master's in counseling education from San Diego State University. She is licensed as a marriage and family therapist in both California and Arkansas. Before we get started, a few housekeeping reminders. Your audio will be muted during today's briefing. However, we encourage you to submit any and all questions you may have using the question box located to the right of your screen. We will present audience questions at the end. Finally, the slides and recording from today's briefing will be available on the Open Minds website by tomorrow. Kim, I'll turn it over to you.
Great. I'm really excited. Can you all see the PowerPoint?
I can, yes.
But yes.
Perfect. Well, I am so excited about this. Thank you for the introduction. I'm really excited about this topic. It's really a topic that's near and dear to my heart, and I'm hoping all of you feel the same way about that. Just a quick overview before we get started. I know many of us have been doing social determinants of health for many years, even before we ever called it social determinants of health. So it's really nice that health plans and others are finally understanding how important it is to look at these social determinants and the various factors and how impactful they are in the outcomes for the clients that we all love to serve. So I'm really excited that this presentation will kind of take some of the knowledge, what we've learned about a particular social determinant and how it has applied and really improved outcomes for some of those folks, especially that really vulnerable population of women and children and homeless pregnant women and children. We're going to talk about a few different topics: homelessness, pregnancy and homelessness, infant mortality, and then finally this great solution that Caresource has come up with. So let's get a little bit started here. In general, when we talk about homelessness, I think it's always important to remember that over a third of all the homeless people in the United States are actually families. And usually that means a mother and her children, and with most of those children being under the age of 5. We all know that homelessness comes with a whole host of other issues with it: multiple barriers to care, the increase in physical and mental health needs, drug abuse, all goes hand in hand oftentimes with that homelessness. But it's important also to remember that for those living on the street or in shelters, there's also an increase in violence. There's also that factor of the lack of privacy and security. Where do you put your medication? So again, homelessness has many different facets to it that we need to consider, especially when we're looking at women, pregnant women. In fact, coming up on pregnancy and homelessness, not surprising, but pregnancy can increase a woman's risk of homelessness. She's more likely to be homeless or become homeless when she's pregnant. And then, of course, pregnant women have much greater pregnancy risk when they're homeless. Women who enter those shelters, we always see a higher rate of drug and alcohol abuse, mental health disorders, and also those complications during pregnancy and birth happen for those women that are housing insecure. They're almost twice as likely to experience a complication, and that often it leads to that early or threatened labor. And of course, we see increased emergency department use among women, especially women who are pregnant, homeless women that are pregnant, than others. And not surprising also is that homelessness and unstable housing during pregnancies, they're just associated with that low birth rate and preterm delivery. So a whole host of issues that come from being homeless or housing insecure or housing unstable, and also being women and pregnant. Kind of leads us to that infant mortality rate. It's not surprising, I guess, if we know that especially women who are homeless and pregnant have many more problems with their pregnancy, their labor, and their birth. But then according to the Centers for Disease Control, the US ranks 33 out of 36 of the OECD countries. You're wondering what OECD's Organization of Economic Community Development, it's about 37 democracies around the world that get together, and the United States ranking 33 out of 36 for infant mortality. This seems preposterous, doesn't it? And then the top 5 reasons, which is not surprising given what we know about especially homeless women who are pregnant. Top 5 reasons for infant mortality: birth defects, the preterm birth and low birth weight, injuries, and then that maternal pregnancy and complications. All feeding into that homeless and pregnant women being homeless. You understand why it's important to address that, of course, from a humanitarian standpoint, but also the impact on the total cost of healthcare. So thankfully, we've got people that are working on those solutions, because we know when someone doesn't have to worry about where they're going to lay their head at night, where they're going to sleep, they not only have the opportunity then to think about and pay attention to their own health, physical and mental health, but it also helps decrease the continued exposure to more disease, more violence, more injury. So it's having that creative solution and having affordable housing or stable housing is crucial. So today's speaker, Kyle Lowe, unfortunately Diane couldn't be with us today, but Kyle Lowe is going to be telling us how Caresource, Healthy Beginnings at Home, has been providing that stable housing to pregnant mothers and improving their maternal health and infant health outcomes. So good job, Kyle. Can't wait to hear about it, and take it away.
Well, thank you very much, Kim. Extremely well-positioned introduction on this topic. If we can move to our next slide. So I will be speaking about how we improve infant mortality and birth outcomes through housing with our Healthy Beginnings at Home program. Move to the next slide, please. So at Caresource, we are headquartered in Dayton, Ohio, but we actually operate in 6 different states. You can see our lines of business here. We're currently serving over 2.2 million members. And something I always like to mention about Caresource is we were actually started in 1989 by Pamela Morris, who is a social worker. She wasn't happy with the service that her clients were receiving in the Dayton area, and she received a $500,000 grant to start the Dayton Area Health Plan. And from there, it has grown into this multi-state, multi-billion-dollar nonprofit organization. Next slide, please. Next. So 4 things to know about housing. This intervention initially began in Columbus, Ohio, so some of these facts are specific to Ohio. But there is no county in the US where a person making minimum wage and working full-time 40 hours a week can afford a 2-bedroom apartment. In Columbus, Ohio, you need to earn $18.41 an hour to afford a fair market rental 2-bedroom. And we know that the minimum wage in Ohio is $9.30. So, you know, it doesn't even come close to covering the amount of money needed to have safe and affordable housing. We also know that most of the households that qualify or are eligible for federal housing assistance don't receive vouchers. And in Ohio especially, more than 356,000 households pay over 50% of their income in rent, which means that they're severely burdened. In the US, on average, for every 100 people that search for an affordable housing unit, there's only 30 units available. Service providers see this commonly, with individuals be receiving housing vouchers, but there's nowhere in the community or the city for them to actually utilize the voucher for housing. And as we stated previously in the introduction, in the US, you are most likely to experience homelessness within the first 5 years of life. So unfortunately, this disproportionately affects children and families as well. Next. So here you can see a slide that demonstrates how housing insecurity and housing instability can affect that normal and healthy trajectory of growth for the mother, the infant, and it persists into childhood. So we see that housing insecurity during pregnancy and especially during early childhood can have persisting effects on the child. They're twice as likely to be in fair or poor health. And they also have higher rates of asthma and chronic conditions that continue throughout their life. Next. An interesting fact that I always like to highlight about housing instability and infant mortality is that there was a study performed in 2019 that demonstrated that housing instability during pregnancy is associated with a 20% higher chance of preterm birth. And this is actually on par with smoking during pregnancy. So something that I like to point out is that let's think about how much time, resources, and honestly bandwidth we see spent on smoking cessation in pregnancy. But do we ever hear about housing? In my experience, no. And not that we don't need to be focusing on smoking cessation, but there also are other factors that are just as impactful that sometimes get ignored. Another study in 2021 by Himmelstein and Desmond found that evictions during pregnancy are associated with worse birth outcomes as well. And unfortunately, during COVID, we knew that Black and Latinx households were disproportionately affected, constituting 80% of households facing eviction. So while we have several studies that demonstrate the linkages between housing insecurity and poor birth outcomes, there's very few studies that show interventions for this problem. So we're going to talk about how it all started. Next, please. So in 2017 alone, in the state of Ohio, they saw a 53% increase from 2012 in the amount of infants that were entering the homeless system in Ohio. Policymakers also were grappling with an increased Black infant mortality rate, and they began to question, is the lack of affordable housing playing a role some way in this? So the OHFA released an RFP for infant mortality related projects in 2017. And in conjunction, the Caresource Foundation, our philanthropic arm, contributed $250,000 in seed funding to start the project off. Next. So this is a timeline showing the intervention. It started in 2016 with advocates lobbying for the passing of a bill that would appropriate funding to support this intervention. And then in 2017, they were taking the proposals for the pilot. And then once Healthy Beginnings at Home was established, we began in 2018, and the program ran until 2020. Next, please. Ohio Senate Bill 332 was very innovative. Without this bill, it would have been a much, much higher climb to be able to implement this program in Ohio. It essentially forced the Ohio Housing Finance Agency to prioritize reducing infant mortality in their annual plans. So for those of us not in the housing world, there's something called a qualified allocation plan, where city governments, state governments decide how that housing money is going to be allocated each year. And the Senate bill required infant mortality to be prioritized specifically, which was able to give the funding for the housing and rental assistance. Next, please. So our intervention and the implementation. So Healthy Beginnings at Home started in Columbus, Ohio as a clinical randomized control study. We recruited 100 women in 13 different zip codes that had high levels of infant mortality, and then they were randomly sorted into control and intervention groups. Next, please. So it takes a village to raise a child, and I also say it takes a village to start a Healthy Beginnings at Home program. We could not have done this solely as Caresource. It was a conjunctive effort between the Homeless Families Foundation, the city government of Columbus. Celebrate One is their infant mortality initiative based out of the mayor's office, and also the Columbus Metropolitan Housing Authority. And then we have great evaluation partners with Nationwide Children's Hospital as well, and the University of Delaware and the Health Policy Institute of Ohio. Next, please. So with our core partners, Celebrate One, our infant mortality, was our lead agency. They coordinated the service delivery for our members. The Homeless Families Foundation worked as our housing stabilization specialists. They provided case management to the women to help them maintain stable housing and to stabilize and be able to achieve self-sufficiency by the end of the intervention. The housing agency was instrumental in supplying housing vouchers for these individuals. And then our Caresource and the Health Policy Institute nationwide collaborated to be the evaluator. Next slide, please. So there was two parts to the intervention for Healthy Beginnings at Home. And the first part was the rental assistance. 15 months of full fair market rental subsidy was paid in combination with 30% of the tenant's income. I'll be honest that over 50% of the women did not have income entering the program, and that tenant responsibility, the average was about $27 per month. So when these women were entering the program, most of them were very economically distressed. So we do the 15 minutes of full subsidy, we do the 15 months or rather of full subsidy, and then we have a 6-month gradual step down period. Something important to note is that some of the moms were not subject to this time limited rental assistance because they were able to receive project-based vouchers through the Housing Authority. And if we go to our next slide, you can see an infographic that demonstrates that step down. So for the first 15 months, the lion's share is being paid through the rental assistance funding. And this is where the housing stabilization specialist is really working with the member so that they're able to take on and shoulder this rental burden through the step down. And then we have a 4-month period at the end where they're assuming the full rental assistance, but still receiving that stabilization case management. Next slide. So the other half of the intervention is our housing stabilization services. These are housing specific case managers who are able to find housing, negotiate with landlords, and also help with any challenges. If there was issues with neighbors, if there was issues with utilities not being functioning, they were able to work with the member and work with the landlord to solve or mitigate any issues. Our philosophy or our methodology that was used was the family critical time intervention. And that is a program that was designed to transition young families from experiencing homelessness to being stably housed in a short period of time. We like to say that the housing stabilization specialists were the secret sauce of this program. As you can see in the quotes from the participants, they had a very, very strong relationship with the women participating in the program and provided a lot of that support network that was desperately needed or missing sometimes. Next slide. So with the step down from subsidies, we did have a 3-month aftercare fund with access to emergency client assistance. Most of us working with individuals that are lower resource or experiencing poverty understand that sometimes something as insignificant as a flat tire or having car trouble, a dead battery can really cause a myriad of issues, anywhere from job loss to missing medical appointments. So we wanted to make sure that once we had the women stabilized, we were still taking care of that little period after. And that 3-month period is actually after the full market subsidy. So month 24 is when the program ends, but there was a 3-month fund with access to the housing stabilization specialist as well. They spend a long time co-creating a housing plan and budget to ensure stability once the program ends. And then we were lucky, I mean, a silver lining of COVID was that there was additional financial assistance and housing stabilization services that were able to be provided past the deadline of the program. Next slide, please. So participant demographics, who were the women that made up this study? If we can go to our next slide, perfect. So while there was no racial criteria for enrollment by nature of doing zip codes with high infant mortality and with women that are experiencing housing instability, we saw quite a bit of racial disparity in the women who fit into that criteria. 81% of our participants were non-Hispanic, Black, or African American. We also saw that the average age of these women was very young, 25 and a half, and 81% had also had a prior pregnancy. And something that I think is very significant is that of all the women who had a prior pregnancy, all had experienced a poor birth outcome, whether that was low birth weight, premature birth, or unfortunately even fetal loss. Next slide, please. So we saw that there was several factors that prevented these women from being able to find housing easily or to access housing on their own. They had had lots of experiences and problems with the housing system. Over half of our women had experienced homelessness in the previous year for a few months or longer. Almost half were concerned with how they were going to pay their rent in the next month. 1 out of 4 desired to live in safer neighborhoods, unfortunately, with project-based vouchers. So these are housing vouchers that are specific to communities. These communities sometimes can be in areas that have a lot of high crime. So we did see women with the desire to raise their children in safer neighborhoods or higher opportunity neighborhoods. And then almost half of the women had moved over 3 times in the previous year. And that's a really good metric to define housing instability as well. Frequent moving, especially for women and families or for women experiencing domestic violence, we often see that they're more likely to be couch surfing or being that informal homelessness because they'll do anything to prevent entering a shelter with their children. So sometimes I like to say that there's almost this hidden epidemic of women experiencing homelessness because they are trying their best to not enter the homelessness system, and therefore they're not being counted. If we can go to the next slide. So the barriers to finding housing probably aren't surprising to anyone who works with individuals that have issues in housing. 40% had experienced past evictions, or having, as we call it in the housing world, that scarlet E on your credit report and record. 42% had criminal records. And then something that was unintended that we did not realize through the study was that electric and gas arrearages or past due debts to the utility companies was a very significant factor in preventing these women from finding housing on their own. The average amount of electric arrearages was over $2,000, and the average amount of gas arrearages was $700. So when these women don't have income, are pregnant and experiencing housing instability, having to pay that $2,000 to even be able to enter a housing unit is a huge barrier for these individuals. Next slide. Some other enrollment demographics. While only 6% were experiencing homelessness at the time of enrollment, over 50% had experienced homelessness in the previous year. And something that's important to know is that the risk of housing instability and homelessness persists for 12 months. So even though someone's not currently homeless in that time, the fact that they have been homeless in the previous 12 months means that they are at a significantly high risk to become homeless or experience homelessness again. All of the women were in the first or second trimester of their pregnancy. And this was important for the research trial because we needed to demonstrate dosage. If we recruited women in the third trimester, it's hard to say that housing really made the difference. All of the women were at 30% of the average median income or lower. So in housing terms, AMI is that median distribution point of family incomes. So they had to be at 30% or lower to be able to receive this assistance. And we saw that 35% had moved 3 or more times in the past 12 months. Next slide, please. So my favorite part, the outcomes and evaluation. We saw very significant outcomes with this program. So if we look at our intervention group, these were the individuals who received housing. We had 51 live births out of 50 women. And the reason it was 51 is because there was a set of twins. In the control group, we had 48 pregnancies, and unfortunately, we did see 4 fetal losses within the study. And these were women, so it's important to say they were still receiving the same health care, same infant visiting programs, same prenatal care, but with the housing, and that's the point of this study, is that the housing is really this key piece. More healthcare isn't showing an impact, it's the housing that needs to be focused on to improve these outcomes. And in the bottom, I do want to point out that it says that this was not statistically significant in terms of research, but this does demonstrate that we need to have a higher powered study. And as we move forward, I'll get to how Caresource and our various partners around the country are working currently to get to that powered study so that we can have an expanded evidentiary base and really advocate for this program at a federal level. Next slide, please. So in both groups, the housed and unhoused, for a healthy or well newborn, the length of stay was 2 days. Unfortunately, for a sick newborn in the housing group, we saw an 8-day length of stay. compared to 29 days for the infants who were in the unhoused group. So what that means is that of the infants who were housed, they were 60% less likely to be placed in the NICU. And of those housed infants placed in the NICU, they were having lengths of stay that were 72% less than their unhoused counterparts. And then we also saw a 3-to-1 ROI and 30-day readmission rates. The intervention group's readmission was 4%, and then the control group's readmission was almost 13%. Next slide, please. In terms of cost savings, we saw significant cost savings to Medicaid dollars with this program. So the average paid claim from the infant at time of birth until release, so cost of labor delivery, possibly NICU, there was a 5-to-1 ROI alone. So we saw in the intervention group that the average cost was $4,000. With our control group, we saw that it was 5 times higher at $21,000. And something that was unintended that we saw that was a great result was that the per member per month spending without outliers for the entire household living at that address, we saw persistent benefits where there was a 2-to-1 ROI in terms of cost saving for the entire household. So this can be mom, other children as well, dad. So this is a huge, huge incentive to try to figure out ways to implement and scale this program to save tax dollars while improving housing and health quality for our members. Next slide, please. So it might not be as significant to our Medicaid folks. As a housing person, I do have to point out that we significantly reduced the burden on the shelter system in Columbus, Ohio as well. So you see before Healthy Beginnings at Home enrollment, within the control and intervention group, pretty similar numbers of days spent in the homeless shelter. But then once we enroll them, you see that significantly it drops for our women who received housing, not surprising. But something that was very important to demonstrate was that after Healthy Beginnings at Home, we saw that there was 0 days spent in the shelter compared to the control group. Next slide, please. So accolades and updates. We were very thankful to receive the 2021 Secretary's Award from HUD for Public and Philanthropic Partnerships. This specifically calls out organizations that are able to blend and braid funding from public, private, and philanthropic resources to create initiatives in housing. Next slide. And when I speak about scaling this study so that we can get to power and statistical significance, in partnership with the Grassroots Maternal Child Health Initiative, which is housed under the IU Richard M. Fairbanks School of Public Health in Indianapolis, we were able to receive a 5-year, $2.4 million HRSA Infant Equity Catalyst grant to implement this into Indianapolis and to serve 50 women to expand the study. Next slide. And also this year in Ohio, we were able to, well, and I guess this is important to say, this wasn't Caresource. So the program was so successful that the State Department of Medicaid was able to fund this through the governor's office. And they provided $2.25 million to implement this program in 4 cities in Ohio to also expand the statistical significance. And this is open to any Medicaid member of any MCO. It is not specific to Caresource. And that's the ultimate goal, is that, you know, we want to prove this concept, but we're not going to be proprietary in the sense that we want the states to adopt this. We want the other MCOs to be using this because it's saving tax dollars, it's helping our members, it's increasing the patient experience, it's helping us achieve that triple aim of healthcare. Next slide. And with that, I want to say thank you to Open Minds and Kim and Brandon for hosting this excellent, excellent roundtable today. I have my email here if you would like to contact me. And with that, I will turn it back to Kim. Thank you.
Thank you, Brandon. Thank you, Kyle. It was so interesting, this whole presentation. I don't know if we have, Brandon, if we have any questions on, but I know I have a few questions starting out. Of course.
None from the audience as of yet, so why don't you go ahead and start with yours, and then if any come in, I'll definitely let you know.
Great. So just to recap and make sure I understand, the program really was about financial subsidy and then those housing stabilization specialists. Is that correct? It was the combination of those two?
Exactly. So I think, and I touched on it earlier, but the point of this study was we wanted to isolate housing as that variable that is making the impact on the infant mortality. So all women received the same usual care and supports, all had access to economic development coaches, all had access to infant home visiting programs, pregnancy programs. There was no difference in healthcare. The only difference was having subsidies for housing and a housing case specialist.
Well, and then will you tell me again, how was the housing actually paid for?
So that is the hardest part of this program with replication. As we know, there's a federal ruling, Medicaid, we are not able to pay ongoing rental assistance. So this is where that public philanthropic partnership comes in, and it is a negotiation partnership, pleading and begging sometimes with your various state housing authorities, your housing agencies within metropolitan areas. So with this, we were able to combine philanthropic funds, which were private funds. Some of them were grants, some of them were endowments, with housing vouchers from the housing authority. So 27 of the women received housing vouchers, which was a huge boon for the program because that was money that we didn't have to fundraise to cover the other rental assistance. For example, in Indianapolis, we're currently working with the state governments trying to figure out a funding stream. For housing folks, we do have to say that there's never been a better time to work in housing. With ARPA, with HOME, there is more money flooding into state and municipal governments for housing than we've seen probably in the last 30 years.
Great. And for the funding for the housing, is that something that Caresource initiated or you went after, or did you work with community partners, or who obtained that money, the housing money, the vouchers?
It was really the collaborative. So with each of these research studies, there's something called the steering committee. So that's the group of all of the different stakeholders. And so within that, there's various work groups. One of them is a housing work group. So that would include individuals that are focusing on state governments and working to appropriate or to get those dollars designated. So while Caresource was a part, we weren't the lead. We were a seat at the table and trying to get that accomplished.
So if some of our provider organizations wanted to participate in this, how would they do that? Sorry about that. I don't know where that's coming from.
If you'd just like to mute yourself.
I will.
So I believe the question was, how are provider organizations able to partner with this? And I have to say that, the proof of concept, and this is hard for us sometimes as healthcare folks, but again, it goes back to housing. So with our provider organizations, they're still able to work with our pregnant women. We're still able to partner, but there's really nothing that would differentiate this from any other pregnancy program for a provider organization. It's the housing piece that's really key, where we have to bring in our community stakeholders, our city governments. So in Indianapolis, it's a good example. We're working with the Office of Public Health and Safety, the Department of Metropolitan Development. You really have to get it. Let me go back. Housing's local. Housing is always local. So you have to have these relationships in the cities and in the areas you are. So to answer your question for provider organizations, get involved with your local council or coalition on homelessness. There's something called continuums of care for housing, or COCs, in every city. That's also another way that provider organizations could get into the fold of this housing. But at the end of the day, it's really for the NCOs to find ways to get housing through the cities that they're operating in, and then we're funneling the healthcare that already exists to those members.
And then we did have one audience question. Aaron Hughes asked if they receive anything else besides housing, like, for example, internet vouchers, food, gift cards, any other forms of support.
So in the initial iteration of the study, which we like to call 1.0 in Columbus, it really was just the rental subsidies and the housing stabilization. So we paid arrearages for utilities, and then there was also utility assistance that's just a part of it. So This housing model pairs with something called the rapid rehousing model. It's a HUD model that moves people from shelters into subsidized housing, and it's time limited as well. So the normal supports that are included in rapid rehousing, which would be utility assistance, deposits, things of that nature, were also included. But when it comes to like vouchers for gas or things like that, no, they weren't specifically given to the individuals.
Kim, you're muted.
Sorry, anything else for today?
One more question. It asks just how are the women recruited? And do you foresee any partnerships with health systems or others as far as like clinic hospitals to help identify women that are in need of this assistance?
So I'm really glad that someone asked that question because I get to talk about something that I get really nerded out about. So Caresource has worked to create a proprietary algorithm that can detect homelessness or members experiencing homelessness. There's two pieces to the algorithm. So one is what we call a descriptive algorithm, or something that's identifying something that's existing. So we use that descriptive algorithm using various attributes to identify our members that are saying that they're experiencing homelessness on an aggregate level. And then we're able to filter down and see zip codes, pregnancy, what point in their pregnancy they are. So that's one way that we recruit. And then if we exhaust that, if we're not able to find women that are willing to join the study, we have another side of that algorithm, which is our inferential algorithm, or what we sometimes call the predictive algorithm. And that is using various attributes that our data scientists have designed and correlated to basically show with 95% certainty that these women are at risk of experiencing homelessness within 3 months. So we are able to predict, and that's really innovative. And maybe that's another conversation, because something that in the housing world is crucial is it is much easier to prevent someone from becoming homeless than it is to take them from experiencing homelessness and have them rehoused. So that was the innovation that we worked on with our data analytics team, that how can we get to these women sooner? How can we get to them before they're evicted? How can we get to them before they're in shelter? Is there any wraparound services, especially with emergency rental dollars? We wanted to make sure that we were creating good pipelines to help these members. And I'll also say that the ultimate goal in Q1 of next year is to start using those algorithms with our life services team and our life coaches to proactively reach out to our members to provide assistance as well. So that's how we're able to recruit the women.
So would you encourage provider organizations, if they want to start something like this, to get their team together and to definitely include the MCOs in their area and ask them to be part of the team?
Absolutely. I think it's MCOs, provider organizations, and then it goes back to the various governmental organizations and nonprofits that work in the housing sector. Housing, I don't know what, it's kind of a cabal, you know, like it's a very similar to Medicaid. It's a very regulated industry. There's a lot to know. It can take 5 to 7 years to become conversant in housing, and then everything changes from year to year. So you really have to know the landscape, know the players, know how to play nice in sharing funding. That's another thing Caresource had to learn, is that, you know, we don't want to come in and just take all the funding in the housing sphere in one city. That doesn't help with goodwill. That doesn't help play nice with all the other individuals who are experiencing homelessness beyond pregnant women. So I do think that you need to do that ground game and that pre-work, learning what the housing infrastructure and landscape is like before you dive into implementing these programs and trying to take dollars from the housing sector.
Terrific. Thank you. Any other questions, Brandon? All right. I think then,
No.
well, are you wrapping up, Brandon, or shall I? We can't hear you.
Yeah,
Brandon.
I'm wrapping up.
Okay.
Oh, yes, I'm wrapping up. Sorry, my apologies. Thank you, Kim, and thank you, Kyle, both for joining us and speaking today. Thank you, everyone in the audience, for joining us today as well. I would like to remind everyone that the slides and recording will be available by tomorrow on the Open Minds website. Also, the full Circle Elite Executive Roundtable series is also available on demand as part of the extensive Open Minds library and can also be found in the brand new Open Minds YouTube channel as well. Please join us next week for our next roundtable, which will be a virtual seminar on Thursday, November 3rd, beginning at 1 p.m. Eastern Time. The topic will be aligning your board to the new sustainability challenges, a 2022 Open Minds seminar on nonprofit management. This seminar will feature Open Minds Senior Associates Ray Wolf and Joseph Costa, and Kim Bond, for a deep dive into the challenges and opportunities and how to update your board on the impacted landscape and the need for updated strategies. Our faculty will outline the skills needed to support modern healthcare in the value-based environment, developing the ability to preserve purpose and knowing when to redefine it, and the ability to monitor finance, business, compliance, and ethics. For a full list of upcoming roundtables or to register for the November 3rd event, please visit the Executive Web Roundtables page under the Events tab at www.openminds.com. Thank you so much. Thank you.
Thanks, Kim and Brandon. Have a good one.
You as well.